Good morning, everyone. So today we are going to start off with some announcements. The first is that you will have your PV exam on July 19th, and we do have presentations scheduled for that day. Also, today you are to go to lab for 1 o'clock because Suzanne is going to be there for the presentation on endovascular techniques. So today we're going to get started. The first procedure we're going to talk about is an endarterectomy. And an endarterectomy is really just removing plaque from the built-up vessel. And to do that, we have to make what we call an arteriotomy into the vessel. And to do that, remember, we use our 11 blade, our pot scissors, and then our DeBakey or Gerald forceps. Once the arteriotomy is made, then the surgeon will be looking for the correct plane between the vessel and the vessel wall and the plaque. And then we're able to remove the plaque. Sometimes we use a freer elevator to help, so it's always good to have one of those available. And then once the plaque is removed, it usually does come out in one piece, and then we really are just ready to close. And so we will have our double-armed Prolene on each side, and the surgeon will close with a continuous suture. Now, I know Jay talked about the carotid endarterectomy. I do have 2 videos that I recommend watching as well after this one. They're really short. It's a back table setup and then a good intraoperative video clip. So, in recap, the carotid endarterectomy is again removing plaque, but now the location is in the carotid artery. And to do that, we have to mobilize the internal jugular vein. And so sometimes the surgeon will mobilize that with clamps, so Bulldog clamps or the Javid shunt clamps, which you can see below is an example of the Javid clamp. Once the internal jugular vein is mobilized, we then move on to the common internal and external carotid arteries, and we expose them and control them along with the clamps. Once the clamps are in place and secured, then we're able to perform the arteriotomy and remove the plaque. Once the plaque is removed, then the clamps are then removed, but they are removed in a special sequence. So the first one that is removed is the common, and then the external, and then the internal jugular vein. Okay. Okay, so the positioning for the carotid endarterectomy is going to be in a supine position with arms tucked bilaterally with a blanket roll under the shoulders. The prep is, sometimes we put those cotton balls in their ear to avoid the alcohol from pooling. And then really we're going to begin at the carotid artery in the neck, go to the ear, behind the ear, down to the clavicle, and up to the chin. And for draping, just like we did with ENT, we're going to make a crushed towel for behind the ear, and then follow that with 4 towels around the incision site, apply Ioban, and use a thyroid drape. Common meds and solutions you will have on the back table are going to be your Hep saline, going to have your 5,000 units and 500 mLs of saline. Next, you'll probably have some sort of antibiotic irrigation, such as Kefsol, and then probably your gel film soaked in thrombin and lidocaine. Common sutures are going to be Vicryl, silk ties, and then of course our double-armed Prolene, followed by our monocryl. And then really dressing, it's going to be a small incision, so probably just Dermabond. And there are the links that I will provide later in a separate kind of area for you guys. All right, so just kind of a reminder that the purpose of utilizing that intravascular shunt in a carotid endarterectomy is to maintain circulation to the brain. Okay, so that's why it's important that we get that plaque out. All right, embolectomy. So remember, embolectomy is either a blood clot or air that is free flowing, and that is an emboli, okay? And what we really do is put in one of those Fogarty type embolectomy catheters. Remember, they come in various sizes, lengths, and really to inflate the balloon, you will need a TB syringe. Okay, pretty easy peasy there. Thrombolectomy A thrombectomy catheter is introduced through the femoral venotomy to extrude the thrombosis. And again, we're still going to use a balloon that is inflated, and then the catheter is carefully withdrawn and pulls the thrombus out with it. The next type of case is sometimes you could be scrubbed in on a inferior vena cava device, which is a small metal device that you can see here that we call a filter, and it traps those large blood clots. And those blood clots will oftentimes want to move throughout our blood into our lungs and our heart. So this procedure can either be done percutaneously, femorally, or through the jugular approach to remove those pulmonary embolisms. This procedure, however, is also performed under fluoroscopy with the C-arm control. And so these patients are normally unable to tolerate systemic coagulation. They may have chronic DVT and tend to have a pretty massive pulmonary embolism. Okay, the next case you could be scrubbed in on is a vein ligation and vein stripping. Okay, and I do have a YouTube video here. Hopefully we can click that. Let's see here. Oh. There we go. These are pretty crazy to see. So this patient has varicose veins, and we are literally going in and pulling out the vein. Oh my. So normally we have just 2 small stab incisions. Sometimes they can use some sort of tunneler. And the tunneler we call is really, it's just really just called a vein stripper. Oh. All right, so the next type of procedure, which some of you have probably already been scrubbed in on, are what we call the venous access devices, otherwise known as a central venous catheter or a central line. So these type of central indwelling catheters are placed to facilitate long-term IV administration for patients with chemotherapy. If they need antibiotic therapy, we're able to inject IV fluids and pain medications. And really this catheter allows the patient to be able to infuse their own IV meds and pain medications at home. Okay. And then the AAA, the abdominal aortic aneurysm. These patients, their aortic wall has weakened and dilation has occurred. We know that an aneurysm is a thin and bulging thrombus, and sometimes, they fill most of the increased lumen, creating a potential source of embolus. And these aneurysms may rupture freely with massive bleeding into the retroperitoneal space, or may rupture intramurally and produce a dissection with significant bleeding, and it can also obstruct the aortic branches. And so to do that, we have to place a graft to repair the aneurysm, okay? Remember, grafts are made from a various amount of material, so they can either be that Dacron type of graft or, again, that PTFE synthetic graft. And whichever graft the surgeon wants to use is sewn into the aorta where the connection of one end of the aorta is placed, and then at the site of their aneurysm on the other end. And to do this with an open technique, it is considered the surgical standard for an abdominal aortic aneurysm repair. If a patient comes in with a AAA, and it's normally going to be an emergency case, complications can arise, such as hemorrhaging, damage to the ureters can occur, and also death can occur. If you're scrubbed in on an emergent AAA, you will need immediately extra laps, 2 suctions, definitely a 10 blade, handheld retractors, and that DeBakey aneurysm clamp ready to go. Here's an example of what the DeBakey aneurysm clamp looks like. Now, of course, there is minimally invasive techniques for multiple things, so the same for a AAA. And we call it an abdominal endovascular aneurysm repair, or an EVAR. And the best method to repair an aneurysm really depends on several factors, including the location and the shape of the aneurysm, as well as the physical condition of the patient. Endovascular grafting is of course, minimally invasive method to treat an aortic aneurysm. And so instead of using the open technique, where we're making that large incision, we're able to do it endovascularly. And so we will put a stent inside the patient as well. And normally it's a stent with kind of that metal wire, and then around it will be made of fabric. And it is inserted into the aneurysm through the small incisions of the patient's groin. And the endovascular repair of the aneurysms, again, do not require that large incision, so these patients will have a shorter recovery period. Now, remember, not all aneurysms are suitable for endovascular repair. So if you're in the hospital and you're on call, that's something that you always want to ask the charge nurse, hey, is this going to be an open AAA, or are we going to do an endo? And then the second type of aneurysm is what we call fusiform, which is pretty much resembled in this picture here. Whereas a pseudoaneurysm, it looks like an aneurysm, but it's really just a bulge on the side, okay? And then the next type of aneurysm is what we call a saccular aneurysm, and that looks a little bit different as well. We'll get more into that when we talk about CT. All right, well, that is all the procedures that we're going to cover today, and I will post the carotid endarterectomy videos as well for you to watch. And don't forget to look at the discussions for some questions, okay? Thank you. If you need anything this week, call Caitlin, okay?